Thank you, everyone. It is now 12:31 p.m., and we will now reconvene the meeting to begin public comments. I'd like to welcome and thank our public comment speakers for addressing the committee today. All the speakers submitted a request in advance of the meeting, and the final list of public commenters was determined via a lottery. For our speakers today, we have a limited public comment period, and in order to make it through all of the listed speakers, it's extremely important that each speaker limits his, her, or their remarks to 3 minutes. We will be displaying a timer on the screen so you know how much time you have left. And as a reminder, our committee appreciates diverse viewpoints that are respectful in nature and focused on the issues instead of comments directed at individuals. We thank you again for your willingness to provide public comment, and we look forward to hearing your comments. Our first public comment speaker for today is Mrs. Christina Dietrich. Mrs. Dietrich, are you on the line?
Hello, yes, I am. Can you hear me?
Yes, please go ahead.
Okay, great. Thank you so much. Oh, 1 second, I'm sorry. I speak on behalf of Delaware Moms Oppose Mandates. Like most of us, I vaccinated my 4 children right on schedule. We trusted pediatricians, FDA, and the CDC. The response to COVID has shattered the trust that many Americans used to have. We're confused and upset. We see FDA members resign, facing political pressure to make approvals. We sounded the alarm on myocarditis long before you acknowledged it. We're told not to trust our lying eyes with a barrage of talking points. There are lies, damned lies, and statistics. This week, Director Walensky said, those unvaccinated with a recent infection were 5 times more likely to have COVID-19 than those recently fully vaccinated without prior infection. Sounds pretty definitive, but actually, among adults hospitalized for COVID-like illness, those with lab-confirmed COVID in the same hospital system within 3 to 6 months were more likely to test positive for COVID-19 than those who had an mRNA vaccine within 3 to 6 months. Can you really extrapolate that to the general public? On the same day, the CDC website was updated to include a systematic review and meta-analysis, which found no significant difference in the level of protection provided by infection as compared to vaccination. When the agency, politicians, and the press tout the hospital MMWR and ignore the meta-analysis, parents wonder when else they promote or ignore research in order to advance a narrative. Immunity is a very salient point in your deliberations today. We know that as of June, the seroprevalence for these kids was 42%. What is it now in November? Parents are already being forced to vaccinate their children in order for them to participate in certain activities. Their risk is so low, and many are immune. They don't do it for the health reasons, but for social consequences. I today propose a compromise. Doses are sent out. We know you will approve this. We beg you to say that kids 5 to 11 may receive the vaccine, not that they should. Otherwise, your approval will be used to enact mandates unjustified by an EUA. They will mandate without evidence that it reduces severe disease or death in children, when it doesn't prevent transmission and the effectiveness wanes over time, when the dosing schedule is suboptimal, when a new buffer is being used, not the one from the trial, when 40% of hospitalizations in these kids are incidental and the remaining 70% of kids have a comorbidity. You won't even acknowledge that the risk-benefit ratio is different for healthy children versus those with risk factors. There are enough unknowns that parents should be able to wait for more data without suffering pressure and coercion. Mandela said that there can be no keener revelation of society's soul than the way in which it treats its children. Our children have given up so much. The benefits of this vaccine for kids are minimal. There are also risks. Protecting the community is not their job. We do not sacrifice the health of a single child to protect adults. That is counter to our nature. Please say that the children may receive the vaccine and not that they should. Words matter. Thank you so much for your attention, and I appreciate the work you're doing today.
Thank you for your comment. And we'll move on to Ms. Patricia Neuschwander.
Thank you for allowing my public comment today. My name is Patricia Neuschwander, and I have been a nurse for 27 years. I am not sure if there is anything I can say to you today to reach you, but I must try. Pfizer's clinical trials did not detect any health benefit at all from their shots. They did not prevent a single hospitalization, ICU visit, MIS-C case, asymptomatic infection, nor death in the treatment group. There was a total of 19 mild infections out of 2,300 children. The injection has not been shown to stop transmission or infection. In a meta-analysis combining from 11 countries, Stanford researchers found that children 0 to 19 infected with COVID have a 99.9973 survival rate. This is a mild illness in the vast majority of children. The science being used for this are small studies using immunobridging, short follow-up times, vaccinating the control group as soon as possible, and excluding any immunocompromised or significantly ill children. It is estimated over 40% of children have already been infected. Prior natural immunity is being ignored. We don't know if giving this vaccine after infection is safe or the consequences to the immune system post-infection. Does it destroy the natural antibodies that you created? Does boosting those antibodies impair the innate immune response to future or other infections? Pfizer's clinical trial in kids was intentionally undersized to hide harms. If the rate of a particular adverse outcome in kids is the result of the shot is 1 in 5,000, the trial only enrolls 1,500, then you are unlikely to spot any particular harm. Supplemental data was obtained from an expansion group of another 1,500, but that data was only followed up for 2 weeks. The follow-up period is intentionally too short. 2 months of follow-up will not provide information on the immediate or long-term safety of this experimental shot. Vaccine effectiveness was inferred by immunobridging data from 16 to 25-year-olds, or junk science. You know this injection will kill and maim some children, some immediately, some in the intermediate, and some in the long term. You know that if you make this general recommendation for all children, it will be viewed as a mandate for all children ages 5 to 11. You can say no. The science does not support this as safe or effective in preventing serious complications or death. Please use your critical thinking, your wisdom, your experience, and be brave. Admit that this data does not support injecting perfectly healthy children. If you listened to the discussion from Burbank meeting last week, you heard several of the committee members had concerns. They were hesitant to recommend the full authorization of this. There is no amount of money, career advancement, or prestige that will make up for the crime against humanity of you recommending this experimental intervention on innocent, healthy children. May God have mercy on the souls of the millions of children who will receive this based on your recommendation.
Thank you for your comment. Your time has expired.
Children. Please do not recommend this for children. Thank you.
We will move on to the next public comment. Speaker, Dr. Andrea Klein Tilford.
Greetings. I am Andrea Klein Tilford, and I do not have any conflicts to report. I'm a pediatric nurse practitioner and the president of the National Association of Pediatric Nurse Practitioners, NAPNAP, professional organization representing more than 8,000 pediatric-focused nurse practitioners. We support the timely and complete immunization of all infants, children, and adults in an attempt to maximize the health and well-being of all people. The last 20 months have brought immense strain to the world, including our nation's more than 20 million 5 to 11-year-old children. Our children have been pivoting in all areas of life. Children can and do suffer acute illness, multi-system inflammatory syndrome, and long-haul physical symptoms from SARS-CoV-2. Data shows children of marginalized racial and ethnic groups have suffered greater disparities. The strain has been immense and has resulted in mental health challenges that will undoubtedly have lasting impacts on social, emotional, and mental health. In a poll conducted by researchers in Chicago, 71% of parents or caregivers believe the pandemic impacted their child's mental health. Pediatric nurse practitioners are on the front line in primary and acute care settings, encountering these challenges in our children each and every day. There has been an alarming increase in child and adolescent anxiety, depression, and suicide. According to the CDC, mental health-related emergency department visits by adolescents increased 31% in 2020. At one point during the pandemic, emergency department visits for suicide attempts in girls 12 to 17 years of age was up 51% from 2019. Eating disorders, serious and sometimes deadly, have increased 62%. And more than 140,000 children have lost a parent or caregiver during the pandemic. Children have paid a significant toll associated with COVID-19, and we have the ability to alter this trajectory. Right now, we rely on masking, physical distancing, hand hygiene, and surrounding children with adolescents and adults who are vaccinated. Without other options, these strategies were acceptable, but are not a long-term solution and leave a tremendous gap in protection for our children. NAPNAP urges the ACIP to authorize the Pfizer-BioNTech COVID-19 vaccine for all children 5 to 11 years and supports widespread equitable rollout to every eligible child in the U.S. using all possible vaccination sites, including primary care offices, schools, pharmacies, pop-up sites, and mobile units. COVID-19 vaccination is safe and effective, and with the adjusted dosing for children 5 to 11, we can protect our school-age children immediately to further shield them from short and long-term physical and mental health consequences and to reestablish more ordinary daily activities. Let's use the newly provided data on the Pfizer-BioNTech COVID-19 vaccine to deliver comprehensive, equitable immunization to all children 5 to 11 years of age. NAPNAP offers provider and family-focused resources about COVID-19
Thank you for
vaccination.
your comment. Your time has expired.
NAPNAP.org.
Thank you. We'll move on to Mrs. Tia Severino.
Yes, this is Tia Severino. I appreciate the opportunity to speak today. I requested to speak after watching the FDA VRBPAC meeting last week. I was heartbroken and outraged at the vote to recommend this vaccine despite legitimate concerns raised by voting members about unknown adverse events and known events such as myocarditis, which has already been observed in 12 to 17-year-olds at startlingly high rates, especially for boys. One member even said, "We won't know the rare events until we start giving the vaccine." This is not okay. The adverse events, which are underreported, are very disturbing. VAERS data as of October 22nd shows 17,619 deaths, 86,542 hospitalizations, 8,656 heart attacks, 2,712 miscarriages, 27,277 permanent disabilities, and 10,956 cases of myocarditis, pericarditis, and this is just scratching the surface. By recommending these vaccines, which are still under emergency use authorization, you are paving the way for mandates in workplaces across the country and in schools. This is an illegal emergency use authorization because there are effective alternative treatments for this virus, which has a greater than 99% recovery rate. I'm begging you to do something you've never done before. Vote no today. There is no reason to give this vaccine to children who are not at risk for severe COVID. We have already seen severe adverse events in the vaccine in the 12 to 17 age group. I will share one with you now. Maddie DeGuerre, a 12-year-old girl, was a participant in the Pfizer COVID trial. Previously healthy, energetic, and full of life, now she is confined to a wheelchair and has to be fed through a tube in her nose. She has been hospitalized numerous times. Maddie and her family have been ignored and dismissed by Pfizer and the CDC. Her voice matters. As the vaccine mandates roll out and people are losing their jobs over a personal medical choice that is their right, it appears you have found a way to get rid of the shaky front line of healthcare practitioners, and soon there will only be compliant first responders, law enforcement, and military. At the same time, you are galvanizing those of us who are against the vaccine and creating greater vaccine hesitancy, including among those who previously believed in the vaccine program. Please, please vote no. I cannot stress this enough. It is wrong to use our children as lab rats, and it is equally wrong to use children as a shield with a failing vaccine. This vaccine is not preventing infection.
Thank you for your comment. Your time has expired.
How many people you vaccinate or how many boosters you give. If you do vote yes, be prepared to face more distraught parents.
Thank you for your comment. Your time has expired. We need to move on to the next speaker. Thank you. Next is Mrs. Claire Hannan.
Good afternoon. I'm Claire Hannan, Executive Director of the Association of Immunization Managers. Thank you for the opportunity to provide comment on behalf of the state, territorial, and local public health immunization program managers. I'd like to take this opportunity to express the critical importance of vaccinating children against COVID, as well as draw attention to two implementation challenges that continue to test public health response. First, I express strong support for a universal recommendation for children aged 5 to 11 years old to receive COVID vaccination as authorized by the FDA. As of October 21st, there have been 6.3 million children who have tested positive for COVID-19, and of those, greater than 1.9 million aged 5 to 11. 8,300 cases have resulted in hospitalization, and 745 children have died. I want to repeat that. There have been 745 deaths in children under 18 from COVID. Some say this illness is mild, but there is no acceptable number of deaths in children. Death is preventable with the vaccine, which is effective and safe. I look forward to the opportunity for children aged 5 to 11 to receive protection through vaccination. Vaccinating kids minimizes disease spread in school settings, and it's the best way to keep our schools safe and open. Next, I want to draw attention to two ongoing implementation challenges. First, the logistical and IT challenges involved with giving half dose of Moderna vaccine as a booster. Jurisdictions and providers have been working diligently over the course of this pandemic and previously through 27 years of the Vaccines for Children program to manage vaccine inventory and avoid waste. But now a 14-dose vial can yield up to 20 booster doses or 14 regular doses or anywhere in between. And providers must manually track how many times they have drawn from the same vial. With the addition of the half-dose Moderna booster and no change to the technology and coding tied to the 14-dose vials, there is no way to accurately track inventory and wastage. The second implementation challenge is the need to provide electronic verification of vaccination and the lack of national standards to do so. There is no standard way for consumers to show digital proof of vaccination. Many states already provide consumer access to vaccination records through immunization information systems, but the lack of a nationally approved standards for QR codes and electronic verification has limited the ability of states to provide an electronic COVID vaccine record to consumers. I draw attention to these challenges so that efforts can continue to develop solutions and improve future pandemic response. Thank you.
Thank you for your comment. Next speaker is Martha Nolan.
Good afternoon. My name is Martha Nolan, and I am speaking today on behalf of Healthy Women, the nation's leading nonprofit health information organization for women, providing consumers and healthcare providers accurate, evidence-based information about diseases, conditions, and innovations in research changes in policy that impact the treatment and care women receive. Healthy Women is also a convener of the COVID-19 Vaccine Education and Equity Project, where we are joined by over 220 organizations representing patients, caregivers, families, diverse communities, healthcare workers, older Americans, veterans, frontline workers, and scientists, all who believe we have a responsibility to come together to provide information about the clinical trials process, regulatory review, and distribution and access to COVID-19 vaccines in a way that promotes equity and trust. Since the start of the COVID-19 pandemic, Healthy Women has been diligent in working to understand the facts of COVID-19 and the related vaccines. COVID-19 vaccines have saved a significant number of lives. A National Institute on Aging funded study published in August 18th in Health Affairs found that COVID-19 vaccines prevented more than 139,000 deaths during the first 5 months they were available, saving 2,285 lives per day. And the estimated economic value of preventing these deaths is close to $1 trillion, but the value to families is priceless. Women are the predominant caretakers in our society and are often called upon to make critical decisions for the health and well-being of their families and communities. Since COVID-19 vaccines were approved by the FDA for adults, women have led in the vaccination rates, with 60% being fully vaccinated compared to men at 55%. But everyone eligible should be encouraged to get vaccinated as soon as possible if we are going to stop the spread of the current COVID-19 Delta variant and, more importantly, the development of new variants not covered by the COVID-19 current vaccine. We need to protect ourselves and, more importantly, our kids and grandkids. Vaccinating our children is the best protection against serious infection, hospitalization, and deaths from COVID-19. Rates of COVID-19 hospitalization among children and adolescents rose to the highest levels in August and September of 2021. Over 8,300 children in the 5 to 11 age group have been hospitalized since the beginning of the pandemic. And sadly, the pandemic has taken a serious toll on our children's emotional and mental well-being. Children need access to safe and effective COVID-19 vaccines to reestablish that safe environment where they can once again learn, play, and socialize without fear of serious illness. We adults started to feel that relief almost a year ago, and finally it's our kids' turn. The COVID-19 Vaccine Education and Equity Project supports the robust regulatory review of the vaccines for children ages 5 to 11 and urges the ACIP to provide the American people with clear guidance on their use. Thank you for the important work you are doing on behalf of Americans of all ages. We remain committed to partnering with you to ensure everyone understands the facts about this critical tool for protection. Thank you.
Thank you for your comment. Next, Dr. Julie Boom.
On behalf of Texas Children's Hospital, I would like to thank the CDC staff and ACIP members who have so diligently analyzed COVID-19 disease burden, vaccine safety, and efficacy data, and then so adeptly provided risk-benefit assessments based on this information. Using your in-depth analyses, my colleagues and I have been able to assure families about the safety and efficacy of COVID-19 vaccines in adolescents and adults. As a general pediatrician with 26 years of experience and director of the Immunization Project at Texas Children's Hospital, I know that vaccines are the best way to protect children from COVID-19. As you continue your discussions today, I urge you not to minimize the disease burden and risk of COVID-19 in children. To date, COVID-19 has proven to be more contagious and deadly than influenza, having killed almost 800 children ages 0 to 17 years, with 172 deaths in children 5 to 11 years. Even though the number of pediatric deaths pales in comparison to the number of deaths among adults, especially the elderly, the risk to children shouldn't be minimized. To frame the number of pediatric deaths, let me offer the following comparison. COVID-19 has killed more children than would fill 2 packed 747 airplanes. COVID-19 has killed more children than would fill 26 full classrooms or 16 full school buses fitting 2 children per seat. During any other year, these deaths would have made national headlines and created an outcry to mitigate the risk to these young persons. Unfortunately, pediatric deaths have been largely overshadowed and as a result may have questioned the risk-benefit ratio of COVID-19 vaccination for children. In addition to the risk of death, we know that many children have experienced the long-term effects of COVID-19. Similar to adults, children are experiencing symptoms such as persistent chest pain, fatigue, and cognitive difficulties long after their acute COVID-19 infection. These debilitating symptoms have prevented their return to normal activity. In addition, over 5,000 children have been diagnosed in the U.S. with MIS-C, multi-system inflammatory syndrome in children. Most often, these children present with symptoms severe enough to require hospitalization in an intensive care unit. Unfortunately, 46 children have died from the severe post-COVID inflammatory process. As mask requirements in schools and public places have been lifted in many parts of the country, recommendations for vaccinating children 5 to 11 years of age with COVID-19 vaccines cannot come soon enough. Children younger than 12 remain a vulnerable population among which COVID-19 can spread. Please give these factors your strongest consideration as you weigh the benefits and risks of COVID-19 vaccine among children. Thank you.
Thank you for your comment. Next is Joan Edelstein.
Thank you. I'm Joan Edelstein, professor of nursing and faculty in the school nurse credential program at California State University, Sacramento. As a pediatric nurse for over half a century, I've seen the devastating long-term effects of infectious diseases. I've personally cared for infants and children with rubella syndrome, polio, tuberculosis, and inclusion body encephalitis from measles. We all know people who've had months of painful shingles due to having had chickenpox. And I have several friends who've had polio and now suffer the effects of post-polio syndrome decades later. As we try to address the highly unlikely long-term effects of clearly safe and effective COVID vaccines, we do not yet know the long-term damage of having COVID in childhood. We do know that children suffer from long COVID, as has been well demonstrated by long COVID kids in the UK. We do know that COVID causes organ damage that may lead to long-term health problems. We do know organ damage can affect children with COVID, as reflected in multi-system inflammatory syndrome. We don't know if organ damage will affect them weeks, months, years, or decades after having been infected with COVID-19, and we should not wait to find out. We ask that you provide emergency use authorization for this clearly safe and effective vaccine now for children ages 5 to 11. Implementation purposes, as a credentialed school nurse, I'd also like to make a statement about the need for the CDC to support school nurses in vaccination administration that will impact the success of pediatric vaccine programs. Our pediatric public health population is right here in our schools, the ideal place to implement primary prevention measures such as vaccines. School nurses are responsible for the entire school health program and are the health experts in this non-healthcare setting. Nonetheless, school nurses have been disregarded. We've been specifically excluded in planning for safe schools in my own state in spite of repeated requests to be at the table. In order to advocate for students and have effective mitigation programs and successful vaccine programs, school nurses nationwide are the public health experts in partnering for successful school-located vaccine clinics and educating families, staff, and the community on the importance of vaccines. The CDC should include in all school-related recommendations that school nurses be actively included in assessment planning, policy, program development, implementation, and evaluation of both vaccine programs and mitigation efforts. Funding should be targeted to school nurse positions as they've now twice the work, uncompensated in time or money, for inadequate pay. Rather than eliminating or ignoring school nurse positions in districts, the CDC should take the lead in recognizing the importance of including school nurses in all recommendations and enjoin state, county, and city health departments to partner with school nurses at the district and school levels to carry out this most critical task of getting our pediatric public health population vaccinated. Thank you.
Thank you for your comment. Our last public speaker for the session is Dr. David Wiseman.
Good morning.
Go ahead, Dr. Wiseman.
Thank you, Dr. Lee. Please refer to our previous submissions for disclosures. Former FDA medical officer Dr. David Gortler just wrote that FDA failed in its duty to ensure vaccine safety for children. After criticizing the UK for rushing to approve Pfizer's vaccine, Dr. Fauci called FDA the gold standard of regulation. With extensive medical industry experience, I say this is the gold standard of regulatory dereliction. FDA touted its children's vaccine review as thorough and transparent. Far from it. For safety, 1,500 patients followed less than 3 months and another 1,500 only 2.5 weeks. A small immunobridging study against Wuhan, still with no immune correlation of protection. A similar study against Delta was marked assay not validated, analysis not verified by FDA. Where is FDA? The efficacy study yielded only 16 placebo and 3 vaccine outcome events. With a large imbalance of mysteriously excluded vaccinated subjects, bias in this observer-blinded but not double-blinded study could drop the 90% efficacy to 0. See today's BMJ for allegations of trial unblinding. Where is FDA? Why was the efficacy analysis not verified by FDA? Where were FDA? Where is Pfizer's sub-study on troponin levels and subclinical myocarditis? Where is FDA? FDA's risk-benefit analysis failed to consider a 42% seroprevalence and non-myocarditis serious AE reports as many as for myocarditis, and improperly modeled waves and waning efficacy. When properly accounted for, we find risks outweigh benefits by nearly 2 to 1 before underreporting. The one thing FDA got right was revealing an almost 5-fold VAERS underreporting at least, and a database more reliable than theirs that CDC didn't know about. Pfizer have changed to a TRIS buffer that could change particle charge, but no assessment of particle distribution in animals, no safety, no efficacy study. Where was FDA? With no cancer or mutagenicity studies, especially in young animals, FDA has not assuaged the concern for radiation-like toxicity of this gene therapy product. With CDC's study on all-cause mortality and vaccination, we find correlations between vaccine coverage and mortality. Adults benefit from 4 to 26 weeks, outside of which there are detriments. In non-vaccinated children, all-cause deaths correlate with adult vaccine coverage. Vaccination already appears to harm non-vaccinated children. Will ACIP request our analysis? No emergency, unblinding, unverified efficacy data, missing and limited safety data, faulty risk-benefit analysis. You have nothing to work with, and FDA have shunted the work of defining risk groups onto you. And one VRBAC member callously remarks, we're never going to learn how safe this vaccine is until we start giving it. FDA have abandoned their responsibility to our children. Will you?
Thank you for your comment. Your time has expired. And with that, we want to thank all of our public comment speakers today. The committee will now recess until 17 minutes after the hour. You have exactly 15 minutes. Thanks, everyone.